Question number 81. We'll talk about, I'm not really expecting you guys to be able to tell the difference between these levels, but we're going to talk about. A 6-month-old male presents with 2 days of vomiting and diarrhea. He is conscious, but his level of activity is decreased. The infant's mother tells you that he has not had a soiled diaper in over 12 hours. The infant's heart rate is 140 beats per minute, and his anterior fontanelle appears to be slightly sunken. You should suspect mild dehydration, moderate dehydration, severe dehydration, or hypovolemic shock. So, I looked in your book, and there's nothing in there in terms of classifications between these. There's nothing that I can point to as far as, 12 hours is one level versus 18 hours is another or something like that. So we're just going to talk about it. The answer is supposed to be moderate dehydration, which I guess if you were to guess might be a reasonable guess, just kind of the one that's sort of in the middle of everything. When it talks about the anterior fontanelle, do y'all remember what that is? Yeah, so remember babies are born with 2 soft spots. On anterior one, which is kind of like essentially right top of the head right here, and then the posterior one, which is kind of like towards the back upper area, those 2. The posterior fontanelle closes in most babies right around or slightly before the age of 6 months, but the anterior fontanelle can take up to 18 months to close. So a question like this, like I said, it would not ask you levels because you're not expected to know that. You would just want to make sure that you understand that this is diarrhea, or excuse me, this is dehydration. Looking at these signs, you should be able to tell. I guess that's all I wanted to talk about. I just wanted to mention it, but it's not a thing that I would expect you to be able to just guess or just know off the top of your head. Number 82. The 6-pointed Star of Life emblem identifies vehicles that A. are staffed by a minimum of 1 certified EMT intermediate, B. meet federal specifications as licensed or certified ambulances, C. are equipped with supplies to manage a mass casualty situation, or D. have complied with state regulations for ambulance certification. Say again?
Is it B?
Actually, the answer is B. There are federal standards, and that's what we go by as far as being considered a licensed ambulance. There are standards according to the Texas Department in terms of what you have to have on the ambulance to run properly, but the Star of Life is a national thing. Which, if you don't know what it looks like, we have one. I mean, it's got extra stuff in it, but it is in the back, the basic Star of Life look. It's an asterisk, again, basically, is all it is. So the answer is B. 83. While jogging, a 19-year-old male experienced an acute onset of shortness of breath and pleuritic chest pain. He is conscious and alert with stable vital signs. During your focused exam, you note that he has diminished breath sounds over the left side of the chest. You should A. administer oxygen and transport to the hospital, B. immediately perform a rapid trauma assessment, C. recognize that he needs a needle decompression, or D. circumferentially tape a dressing around his chest. So A is definitely the correct answer. When we're talking about patient assessment, we know that oxygen is right up at the top. Rapid transport makes sense because of those diminished breath sounds and that chest pain. What do y'all think might be happening with this guy, most likely? Probably a pneumothorax, yeah. At a basic glance, that's what makes most sense. That's why C is on there as an answer choice. Recognize that he needs a needle decompression, and that is not something that we do. That is not a basic level skill, but do you know what that's referring to? Yeah, they put a needle in their chest, not all the way into the lung, just into the chest cavity, because that's where the air is building up to basically vent and allow that air to get back out again. Otherwise, because it has nowhere, it can't go back up because it's not in the lung anymore. So that's what that's referring to. Has anyone ever seen the movie Three Kings? It's I may have asked you guys this already. I don't know. It's got George Clooney and I think Ice Cube. Yeah, no, and somebody else whose name I don't remember, but it's an Iraq War movie. I think it's Mark Wahlberg. I don't know. Maybe it's Matt Damon. It's one of those. It's one of those guys that they look a lot like me. Anyway, one of the main plot points partway through is the guy has a pneumothorax and he has a constant vent. He in his chest. I say constant. They stuck a syringe in and left it open. It's actually sort of a comedy for a Iraq War movie. It's interesting. It's actually a really good one. Total side note. But the answer here would be A. Question number 84. A 19-year-old male was stung multiple times by fire ants. He is experiencing obvious signs and symptoms of anaphylactic shock. You administer 100% oxygen and give him epinephrine. We don't do subcutaneous, so just say via autoinjector. Upon reassessment, you determine that his condition has not improved. You should A, transport him immediately and provide supportive care while en route. B, consider that he may actually be experiencing an acute asthma attack. C, repeat the epinephrine injection after consulting with medical control. Or D, request a paramedic unit that is stationed approximately 3 miles away. So remember, if a patient has, like I said, this question, we don't do the subcutaneous injection. So assume he had an EpiPen. You'd be administering that EpiPen via autoinjector. That's how it works. If it did not have an effect, what you'd want to do is ask the patient if he had another EpiPen and try to get medical control to allow you to redeliver, because you can deliver more than one dose. You can try again. So the best answer here is C. I would slightly reword this for the question for next year so that it's more clear, like with the tools that we use. But you should be aware that epinephrine you can give more than one dose of. If your patient isn't improving, you can ask, again, you'd have to call back up medical control and say, hey, my patient has another EpiPen. There's no improvement in his condition. His blood pressure is still whatever the number is. And they might tell you that you can go ahead and try another one. 85. You've applied a zippered air splint to a patient's left arm. During transport, the patient complains of increased numbness and tingling in his left hand. You reassess distal circulation and note that it remains present. Your most appropriate action should be to A, elevate the injured arm and reassess distal sensory function. B, inflate the splint with more air until the patient is comfortable. C, assess the amount of air in the splint and let air out as necessary. Or D, remove the air splint and reimmobilize with padded board splints. Yeah, this is just like that answer, or that question where the patient had the slightly too tight, like gauze roller bandage on. Same deal. If it's a little bit too tight, you reassess and potentially change the tightness, which in this case would be to maybe change the amount of air. Let a little bit out so it's not pressing so hard on the arm. 86. During a mass casualty incident, the incident commander assigns you to the triage area. You should A, report to the area and perform only the duties that you have been assigned. B, perform the requested duties or tasks and then report to the staging officer. C, report to the triage area but leave if there are no patients that require triage. Or D, complete the assigned task and then go to another area and assist as needed. Okay, so we'll talk through each answer choice. It's fine that there's some confusion about this. This side of things, operations, is not something that you probably focus on because we think so much in terms of treatment and problems. But remember, 1/6 of your test is going to be operations-based. Everything from communications, legal, mass casualty, like incident command type system stuff, how you're going to lift and carry and move patients, all of those questions that don't automatically fit in one of your like treatment categories or patient categories, they're going to be in there. So you may not get a question exactly like this, but you also might. And you need to be familiar with all of your operations stuff because there's a lot of different things fall into that category. Okay, so A says, report to the area and perform only the duties that you have been assigned. So on first glance, this looks pretty good. You're going to report to, you're going to do what you were told, go to the triage area, performing only the duties that you have been assigned. Don't get too hung up on that word only. Because at first it sounds like maybe you're not going to properly do your whole job, I guess, if you're thinking about it that way. Really what it's saying is stick to your job. Stick to your scope. If the incident commander assigns you a specific task, or maybe the triage officer assigns you a specific task, do that task. Because otherwise you're going to be stepping on somebody else's toes. If you try to do too much or try to do something that's outside of the scope of what you have been instructed to do, then maybe something is going to get done twice by two different people and something else isn't going to get done at all. So the whole thing with this incident command system is to make sure that everyone has a task and does that task, and so everything is accounted for. So A is a pretty good answer. Look at the others. Perform the requested duties or tasks and then report to the staging officer. Well, the only problem with this one is that the staging officer in an incident command system is responsible for resources, you know, how you have your resources arranged in terms of where the locations are that you're going to be doing maybe decontamination versus treatment versus this or that or whatever. They're not the person that's actually in charge of telling you what to do. They have a job, but you don't report to them. You would report to your triage officer, also to the incident commander. You'd have that chain. But staging is literally talking about making sure we have all the resources we need and they're in the appropriate places. And so that wouldn't make sense. C, report to the triage area, but leave if there are no patients that require triage. Definitely not, right? Just because there's no patients now doesn't mean there won't be any patients. If you're required to be in triage, you should be in triage, not assume that they don't need you. And that's actually the same reason that D is also wrong. You complete the assigned task and then go to another area and assist as needed. Again, you follow the directions that you're given. So even if you think maybe you could be more help somewhere else, trust that the people who are looking at the whole situation know what's going on. Follow whatever you're told to do by the person who's in charge of you, your boss, essentially, at that point. So A is the best answer because A is most accurate. Everything else doesn't fit within how that ICS is supposed to work. 87. Upon arriving at the scene of a major motor vehicle crash at night, you find that the safest place to park your ambulance is in a direction that is facing oncoming traffic. You should A, turn your headlights off. B, quickly access the patient. C, place a flare near the crash. Or D, turn all warning lights off. What do y'all think? Okay, I'm hearing all the options again. So A, turn your headlights off. This is actually the best answer in this case. Remember, your headlights are big and bright and white. They're going to be shining. If you're facing oncoming traffic, then your headlights are shining directly at every car that's passing you by. And if you've driven anywhere at night, you know how annoying that is to have to face headlights. So make it a little bit easier. Those headlights aren't going to do you any good in terms of treating your patient because they are so bright. They're not going to attract any attention. What they might actually do is blind the other drivers on the other side of the road by having a continuous beam like that. It's like if somebody was driving constantly with their brights and did never like flash them low when you drove past. That's super annoying. So go ahead and turn your headlights off in this case. What? I hate it so much when they do that. I say lots of angry things in my car. B, quickly access the patient isn't really answering the question. So you do want to access the patient, but it doesn't answer this idea of safety, which you can tell this question is clearly wanting to know what is the safest or best option in terms of the whole situation. So yeah, you'd want to access your patient, but you'd want to assess the situation, and that doesn't really fit yet. Place a flare near the crash. You do sometimes use flares, warning cones, different options that you're going to have. You know, you'll be wearing a vest, things like that if you're working at night. But compared to turning your headlights off, it's not as good of an answer. And D would be wrong because you don't want to turn all your lights off. Those lights on your ambulance are super, they're going to attract all your attention. They're going to make people look at you, and that's what you want. You do want to be seen because you want the crash to be seen. So turning all of those lights off isn't going to help you at all. Those lights are not going to be near as annoying as the two high beam headlights are. Turn the headlights off, leave all the other lights on, turn off the sirens, make sure it's marked appropriately, and that's how you'd want to make sure that the whole scenario is safe. To try to have as few scene hazards as possible. Because being on the road is pretty dangerous anyway. You don't want to make it worse by the way you're reacting to it. Question number 88. After eating at a local restaurant, a 20-year-old male complains of blurred vision, difficulty speaking, and difficulty breathing. He is conscious, however his respirations are profoundly labored and producing minimal tidal volume. You should A, apply oxygen via a non-rebreathing mask. B, position him supine and elevate his legs. C, request a paramedic to administer atropine. Or D, assist his ventilations with 100% oxygen. So yeah, the answer to this, is actually really simple. Like you said, it's D, assist his ventilations with 100% oxygen. You guys know this. He has difficulty breathing, and then the minimal tidal volume. Like we've said every time, that shallow respirations or minimal tidal volume, you know he needs BVM. So the best answer here is D. If instead of saying like difficulty speaking and difficulty breathing, they had said dysphagia or dysarthria, those both refer to like difficulty of speaking, slightly different mechanisms, but essentially the same thing. Or if they said dyspnea, you should also know what those are. So y'all know how to say y'all know how to spell dyspnea, right? Okay. Dysphasia is stupid thing. So same beginning for difficulty, that dys start, but phasia is talking about speech, difficulty of speech. So that would be a good vocabulary word that might pop up on a test question that you should probably know. If they say, you probably wouldn't see this as commonly, but dysarthria is talking about difficulty of finding the correct word or putting the words in the correct order. So if dysphagia is actually like difficulty of speech, dysarthria is more like the difficulty of the words, I guess, if that makes sense. Or wait, maybe I'm backwards. Sorry. I think I'm correct. So, flip those around. Dysphagia is difficulty in terms of picking the correct words or putting the words in the right place. Dysarthria is difficulty in actually articulating the words, saying them correctly. So think about that. Articulating, that arthria side of it, that's what you should keep in mind. As soon as I said it, it sounded wrong. I just had to check and make sure. Okay. Number 89, excuse me. A 43-year-old man is experiencing a severe nosebleed. His blood pressure is 190/110, and his heart rate is 90 beats per minute and bounding. Appropriate treatment for this patient includes A, having the patient pinch his nostrils and then lie supine. B, pinching the patient's nostrils and having him lean forward. C, placing a rolled 4x4 dressing between his lower lip and gum. Or D, packing both nostrils with gauze pads until the bleeding stops. B. B is the most correct answer. You want him to lean forward so that it's not going to cause any airway or breathing obstruction. So it definitely wouldn't be A, because you would not want to lean back and have that blood draining like that. And then the other two just don't make sense. You don't ever like pack something in, so putting gauze in the nostrils isn't the correct way to deal with it. And placing, what it's saying is to place the dressing like here inside the mouth. Again, that doesn't make sense if you have a nosebleed. So the only good answer here would be B. 90. You are dispatched to a local elementary school for an injured child. As you approach the child, you note that he is lying at the base of the monkey bars. He is not moving and does not appear to be conscious or breathing. You should A, begin immediate rescue breathing. B, stabilize his head and open his airway. C, perform a head tilt chin lift maneuver. Or D, assess for the presence of respirations. B. I believe we talked about this, how if you've got an issue, remember that manual stabilization of head is very, very first, and then you do your ABCs, and then later on down you could do the rest of your spinal immobilization. But that manually stabilizing the head, as soon as you suspect there's a spinal injury, you have to do that. And you should suspect a spinal injury because he's lying at the base of the monkey bars. You don't know what happened, but just based on his positioning, you might think that he fell and maybe hit his head or hit his back or something. And remember, for a patient like this, how would we open their airway? Jaw thrust, not the head tilt chin lift. So B was the best answer. Good job. 91. A 56-year-old male is found semi-conscious by his wife. Your assessment reveals that his respirations are rapid and shallow, his pulse is rapid and irregular, and his blood pressure is low. The patient's wife states that he complained of left arm pain and nausea the day before, but would not allow her to call 911. The most likely cause of this patient's present condition is A, acute myocardial infarction, B, cardiogenic hypoperfusion, C, severe septic hypoperfusion, or D, a ruptured aortic aneurysm. So I see why you said A. The actual best answer here is B. So the key to, oh, sorry, Randy's calling me. Okay, so the key here is that in A it says an acute myocardial infarction. Remember, when we're talking about something that is acute, we're talking about a sudden, rapid onset. We were usually talking about a more severe condition. So an acute myocardial infarction would be something that like had just happened rapidly and really decreased functionality for this guy. He had a massive heart attack. He had an acute myocardial infarction. You'd want to put those things together. In this case, clearly there's a heart issue, but we wouldn't call it acute because it's a day later and he's still alive, basically. And if it had been acute, it wouldn't be in these conditions. Does that make sense? So that's why because acute isn't the best word there. So we can't say that that's the correct answer because the word is incorrect. Cardiogenic hypoperfusion is simply shock that results from a heart problem. So that word cardiogenic, remember, anything that ends with genic, we're talking about the genesis of it or the beginning of it. So cardiogenic, it began in the heart somehow. It doesn't say exactly what caused it. It'll usually be a weakening of the heart, whether they have like a chronic condition like CHF, or they had maybe a small heart attack or something. That part isn't like explicitly said, but the idea is that something in the heart is messed up and that is causing overall hypoperfusion, causing shock because now the heart isn't pumping blood well, and so the blood is not getting where it needs to go. You have poor perfusion, you have low blood pressure because the heart is no longer pumping appropriately how it should. And that makes sense here because he clearly had something going on yesterday, left arm pain and nausea. He might have had a small heart attack, didn't get anything fixed, his heart was damaged, and now his blood pressure is low because his heart is malfunctioning and failing. Typically somebody who's in cardiogenic shock or cardiogenic hypoperfusion, it's not going to get better. It's pretty much irreversible because it means that they had a problem that they didn't fix. And their heart is going to continue to stay weak and not able to pump well and eventually just give out because the muscle is so weak. So cardiogenic hypoperfusion is the best answer here. Severe septic hypoperfusion, what is that? Hypoperfusion is shock, right? As in like low blood pressure, blood not getting where it's supposed to go. So a septic shock, what is the origin of that one? If somebody has sepsis or has septic shock.
Is it like a backup?
Septic shock or sepsis would have to do with an infection, like a systemic infection. So it can come from something small. If you had a smaller infection, even like a cut on your finger that got infected. It doesn't happen often, so I don't want y'all to freak out about paper cuts, but just something that starts out as a small infection can become systemic if the infection gets untreated and moves through the body well enough and kind of reaches the important parts. And severe septic hypoperfusion is when the whole system is so messed up by this infection that it can no longer dilate those blood vessels, it can no longer dilate and constrict as necessary, so they just stay dilated, like they're big and leaky, and that's what causes the hypoperfusion, because the sepsis has just overwhelmed the system and it can't properly function anymore. And we've talked about aortic aneurysms, what they are, what they look like. If it ruptures, obviously this patient is bleeding out in a matter of minutes. They're not going to last till the next day. So the best answer here was B, but we did talk about everything else. Any questions about these conditions or any other types of shock or anything like that? Okay. Number 92. You have immobilized the spine of an 81-year-old female with a head injury. During transport, you note that she is experiencing signs of intracranial pressure. In addition to reassessing her ABCs and providing the appropriate treatment, you should A. Elevate the foot end of the backboard 6 inches. B. Place several layers of blankets on her. C. Elevate the head end of the backboard. Or D. Allow her to sit up on the backboard. C is the best answer here. Elevating the foot end and putting layers of blankets on or dealing with shock. This patient doesn't have shock. She has intracranial pressure. You want to use gravity to help you with that. So between elevating the head end or allowing her to sit up, why is sitting up not appropriate here?
Because she's obviously had head injury, so a spinal injury.
Yeah, you've immobilized her. So you're not going to unstrap her and let her sit up. You just slightly incline the backboard so that her head is up a little bit. The whole backboard should be on a slant. 93. A 33-year-old male sustained an abdominal evisceration to the left lower quadrant of his abdomen after he was cut with a large knife. After appropriately managing his airway and assessing him for other life-threatening injuries, you should care for his wound by A. Irrigating it with sterile water and then covering it with a dry dressing. B. Covering it with moist, sterile dressings, secured in place with bandages. C. Covering the exposed bowel and keeping his legs in a straight position. Or D. Carefully replacing the exposed bowel into the abdomen and transporting. The best answer here is B. We know that when we've got that abdominal evisceration, that means there's a part of bowel sticking out. Cover it with a moist sterile dressing, secure it in place with bandages, is your best way to do it. You don't want to use a dry dressing because it's typically in a moist environment and you're trying to maintain that. And C just isn't as precise. It does say to cover it, but it's not talking about the type of dressing. B is a more precise answer, and that's why it's the better answer, because it's assessing, or it's addressing that particular situation, not just a general wound thing. 94. Following blunt trauma to the abdomen, a 21-year-old female complains of left upper quadrant abdominal pain with referred pain to the left shoulder. Your assessment reveals that her abdomen is distended and tender to palpation. On the basis of these findings, you should be most suspicious of injury to the A. liver, B. spleen, C. pancreas, or D. gallbladder. So to answer this question, you've got to remember your anatomy, abdominal anatomy. Remember your abdomen is divided into 4 quadrants. Actually, let's draw this a little bit on the blank space, I guess. So if that's the stomach, or if that's the abdomen, that's the belly button right there. You would have like the chest up here at the top, and then obviously the legs down below. But this is the abdomen, what we're dealing with. So for the abdomen, remember, we would divide it essentially evenly with the navel at the center. And remember, if you're looking at a patient, you're dealing with left and right according to them. So if you're looking at this patient over, well, I guess you can't really see what I'm going to be pointing at, but over here you've got the left upper quadrant, right upper quadrant, left lower quadrant, and right lower quadrant, right? So you're looking at him, and that seems reversed to you based on your right and left, but you got to think about your patient who's facing you. There are certain organs in the abdomen that you need to know. You don't need to know every single bit of every single organ that's there, but you got to know generally what's where. So starting in the right upper quadrant, what do we know is there? Liver, and what else? Yeah, liver, it's going to be kind of big, and gallbladder. Left upper quadrant. You have the stomach. You do have the pancreas. It's smaller, but it's there. You also have the spleen. Okay? Right lower quadrant. The main one that you should remember. Appendix is down here. And then left lower quadrant, what do we usually talk about? The colon. And really, the colon is like reaching all the way through, kind of behind and around everything else, or rather the intestines are. But the colon itself is mostly in that lower left quadrant, the part that we talk about that might be feeling pain. Anyway, this is how we divide it. That's what we think about. Obviously, small and large intestines are in the middle, and obviously there's some overlap between the organs. So you have a patient who has left upper quadrant abdominal pain. So we're looking at these organs, right? Stomach, pancreas, and spleen. With referred pain to the left shoulder, which is pretty typical when you have an abdominal injury. You usually have referred pain somewhere based on the way the nerves work. So, based on the organ that we're dealing with and our answer choices, what can we at least narrow it down to? Spleen or pancreas, because liver and gallbladder are right upper side. So you know automatically it wouldn't make sense for it to be those. Between the spleen and the pancreas, anyone want to guess at the correct answer? The spleen is the correct answer. Okay, so the spleen, for one thing, is located more anteriorly and also more laterally than the pancreas. The pancreas is, you'd have to look this up in your books to see the actual like location, but it's kind of tucked sort of below the stomach and also kind of in like within a little curl of the small intestine. So the small intestine is sort of wrapping around it. Basically, the pancreas is pretty well protected. It's pretty internal. It's got, the stomach and other things kind of all around it. And the likelihood of it being the thing that is most hurt following blunt trauma isn't super likely. On the other hand, the spleen is sort of over here on this side and slightly towards the front. It's much easier for it to be hit and damaged during blunt trauma than for the pancreas. So the spleen would make most sense here. Also, this is something that you might want to be aware of. The pancreas refers pain to the back, typically, not up to the shoulder. The liver and the gallbladder go to the right upper shoulder. Spleen goes to the left upper shoulder. Pancreas goes to the back. Abdomen has that weird like rebound pain where you press down and it actually hurts worse when you're coming back up than when you press down. Those are the, I guess, kind of weird pains that you should be aware of when it comes to the abdomen. So the answer here would be spleen because it best fits the situation that we have. 95. A 22-year-old male was kicked in the abdomen multiple times during an attack by a gang. He is conscious but restless, and his pulse is rapid. Your assessment reveals a large area of bruising to the right upper quadrant of his abdomen. The most appropriate treatment for this patient includes A. Preparing for immediate transport, B. Applying oxygen via nasal cannula, C. Performing a focused physical exam, or D. A detailed assessment of his abdomen. So some people said B as the best answer. The reason why it would not be correct in this case is because you're delivering via a nasal cannula. So this is a basic rule of doing the National Registry. If part of the answer isn't the best choice, usually the whole answer isn't the best choice. Meaning, if he really needs, we don't know much about his breathing, but I would assume probably a non-rebreather. He needs higher flow oxygen because of this abdominal issue. And if the only choice that you've got is nasal cannula, it's probably not the best choice. Even though you think oxygen is good, nasal cannula is what makes it not as great. So in this case, B wouldn't be the best answer. C, performing a focused physical exam, not bad. You do want to examine this person's body, specifically their abdomen, that area that you seem to, that the pain or the problem seems to be centered in. C and D are kind of saying the same thing, honestly. A focused physical exam and a detailed assessment of his abdomen. They're both talking about specifically physically examining the part of him that hurts or has the most signs of trauma. The best answer here, though, actually is A, preparing for immediate transport. The fact that he's conscious but restless with a rapid pulse and a lot of bruising. Remember, right upper quadrant, we just talked about that. That's where your patient's liver is, right? The liver holds a lot of blood. So the fact that you're seeing bruising and he was hit up there means it's possible that he is bleeding internally. And that kind of fits with this idea of being conscious but restless with a rapid pulse. Those are signs of shock. Or at least those are signs that could point to shock. They are not always, but they could in this case. It makes sense that he'd be going into shock. And because of that, the best answer would be rapid transport. Because when we deal with shock, we deal with high flow oxygen, keeping them warm, elevating their feet, and transport are like the main ways that we handle it. And the only one of those that's on this list is transport. So it's the best choice. Does that make sense? Okay. 96. A 4-year-old female pulled a pot of boiling water from the stove. She has superficial and partial thickness burns to her head and anterior trunk. What percentage of her body surface area has been burned? So this is one of those you have to remember your rule of nines. They're in the book, the little diagrams are. And I have one on the next slide, but I want to see if you guys can remember before we go to that.
18.
Okay. So we'll just go to the slide here. Okay. So you should be able to see the child well enough. Now, infants is very slightly different from the child proportions, and really the only difference all the way up from adult down to infant is the proportion of head versus legs. So For adults, their head is proportionally smaller, their legs are proportionally larger, and for children and infants, their head is proportionally larger, legs are proportionally smaller. So sometimes you'll see like a sliding scale of you have to take the patient's age and approximate size into consideration and do some math. For the sake of the test, it's pretty basic. You're going to use these numbers. You don't have to do any weird like figuring between their age and whatever else. But you've got this child who was, what did it say? Head and anterior trunk, right? So anterior trunk, yeah, means her front, specifically means the chest up. Trunk versus like abdomen, it's what it's trying to talk about. Or torso versus abdomen. You also have her head, right? His or her, I don't remember. Her head, which is another 18%. So you've got the 18% from the head and the 18% from the body, which would make 36 be the best answer.
I was
Yeah.
thinking 9 for the adult head.
Yeah.
And I thought front was 9 and back was 9.
Yeah. No. If you have to, think about it real quick, remember there's, at least for an adult, which is why it's called the rule of nines, because everything is a 9. The head is 9, 9, 9, 9 upper back, 9 lower back, 9 for each arm, 9 for the front of each leg, and then for the back of each leg, and that's 11 nines, which is 99%. So the 1% left is genitals. So if you're trying to remember it, you can just try to like count out how many nines can you think of, like 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. And then 11 nines plus the 1% for genitals, that's 100% of the body. Another way to do this when you're actually out in the field, it's having trouble reconnecting. One way to do this when you're out in the field, you can do this, which it's pretty easy kind of as a general tool. Also, if the burn shape or size is kind of irregular or not easy to quantify by these numbers, usually the size of somebody's palm is approximately 1% of their body. Close enough, anyway, that you can use that as a, like, okay, 1, 2, 3, 4, 5% of your body if it's like just your shoulder that was burned or something. Okay, 97. The eyeball itself is referred to as we already talked about this, orbit, globe, sclera, or cornea. Globe. The orbit is what it sits inside, also called the socket. So like the skull part is the orbit, and the globe is the actual eyeball. Remember, the sclera is the hard white, or it's the tough, not hard per se, but it's the tough white covering of your whole eye, and the cornea is on the front. 98, we're not going to mess with because it's IVs, and we don't do IVs. 99. The purpose of the pediatric assessment triangle is to A, determine if the child's vital signs are within the age-appropriate limits. B, allow you to rapidly and visually form a general impression of the child. C, facilitate a rapid head-to-toe assessment of the child by visualization only. Or D, gather critical data by performing a rapid hands-on assessment of the child. Do y'all remember the pediatric assessment triangle? Okay, well, conveniently, I have one for you. So, it is ABC. It's a different ABC from what you think of as far as like airway, breathing, circulation. Appearance, so that's talking about when you look at the child. That's talking about when it says, hopefully you can read this from where you are, abnormal tone, it's talking about like your muscle tone. Overall kind of the way you're reacting, or the way the child, rather, is reacting to stuff. And this is in your book, but we are going to talk about it just here a little bit. Along with appearance is interactivity. So again, is the child interacting with their environment? Do they seem involved in it at all? Consolability, meaning if the child is crying, can they be easily consoled, or are they just uncontrollably crying, nothing is reaching them? Abnormal look or gaze, abnormal speech or cry. So this appearance is just sort of generally when you're looking at the kid, do they look like they're interacting normally with their world, or do they look like they're not really connected to it? Because they're not interacting with it, or they're not like communicating or, functioning normally with how they would be. That's appearance. B is work of breathing. So essentially, how hard are they having to work to breathe? A typical child who's breathing, they use their diaphragms a ton. So you might see their, maybe a little bit of like their stomach coming out is fine. That abdominal seesaw happens with kids sometimes. But what if you're hearing abnormal sounds? Wheezing, stridor, coughing, Rales, that crackling sound in the lungs, all those options. You want to listen and see if you can hear anything with their breathing. If they're having to work hard to breathe, you'll probably hear something. Abnormal positioning, what are we talking about with that? Like tripoding. So if they're leaning over, because it's easier to breathe when you're leaned over. So if they're leaning over and like supporting themselves on their hands, that's that classic position we call tripoding, because the arms and then like the trunk is just 3 ways that they're supporting themselves. And that's really specific if you see that. Retractions, what are retractions?
In the back where it's
Yeah, so retractions, we saw those videos where it's the muscles that, all those extra accessory muscles that people use to breathe. If they're trying and they're failing at breathing well, you're going to see those muscles, they're not going to be doing you any good. They're just going to be like sucking in with every breath. Every time you breathe, they're going to be moving along with the air. Because they're essentially useless. You're trying so hard to breathe, and they're just not cutting it. And so you're going to see, like, the skin and the muscle between the ribs is going to go in, and then it's going to push back out when you're breathing out, because of all that pressure you're pushing out of your lungs. Flaring, we're talking about nasal flaring. So that would be if their nostrils, again, it's part of that whole positioning thing. If they're leaning forward and they kind of look like they're, like, sniffing the air, trying to get more in, they're trying to get that airway as open as they can. You're going to maybe see their nostrils flaring a little bit, just kind of, again, trying to open up and get as much as they can. And apnea is no breathing, and gasping, obviously, we know what gasping looks like. So you're going to look at your pediatric patient to see, does it look like they're having to work to breathe? Do you see any of these weird sounds, positionings, all these unusual things that don't accompany normal breathing? And then circulation to skin is essentially looking at skin color. You don't actually have to touch the child to assess this. You're just wanting to see, what does their skin look like? So pallor, meaning that they're pale or ashy colored. Mottling, do you remember what that is? It's like people with poor circulation can have mottled skin, kind of alternating patches of like really pale and kind of like purpley, pinkish, reddish. You'll see it's patchy skin. And then cyanosis is bluish. So when you're looking at a child, before you even have to touch them, you can use this, and you don't have to remember every single thing that's underneath it, because most of it's instinctive. You can tell if a child looks weird when they're breathing or is making a noise. You don't have to think about, let me assess their sounds. You just have to see, do you hear anything? Does that make sense? You don't have to think about, let me assess whether they have a normal cry. You're just going to be listening, and you're going to be able to tell if it sounds weird or gasping or inconsolable or whatever like that. These are just the things that you may notice if a patient is having trouble. So all of those things together help you get a general impression of your patient before you touch them. So the answer here would be B, yes. Pediatric assessment triangle allows you to rapidly and visually form a general impression of the child. Remember, pediatrics and OB-GYN is another whole 1/6 of your test. Just like I talked about operations, pediatrics and OB-GYN, meaning questions relating to pediatric patients or pregnant patients or infants, is a 1/6 of your test. At the minimum, you're going to get, 15, 20 questions on that patient set. Maybe more if you're having trouble with it. They might ask you more and more questions. So you do need to know your pediatric stuff pretty well. (100) During your treatment of a 4-year-old male with a complete foreign body airway obstruction, he becomes unconscious. You place him supine on the ground and attempt ventilations. However, the child's chest does not rise. You should A. Perform 5 abdominal thrusts and reassess. B. Open his airway and perform a finger sweep. C. Deliver 5 back blows and 5 chest thrusts. And D. Reposition his head and reattempt ventilations. The best answer is D. Yes, correct. So remember, if you're dealing with a conscious patient who has a complete foreign body airway obstruction, basically they're choking. They like to use the long terminology. You'll see it as an FBAO, like abbreviated, but they mean choking. Something is there and they can't breathe. If they're not choking, you can perform abdominal thrusts to try to get this thing out. However, if they become unconscious while you're dealing with them, you need to lay them down on the ground, open up their airway, Look and see if you see anything in their mouth. If you see something, you can try to do a finger sweep to get it. Remember, you don't ever, 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 with any patient, do a blind finger sweep where you just stick your finger in and try to feel for something. More likely than not, if there is anything there, you're going to just push it farther down inside the person's airway. Once you've opened their airway and done that quick finger sweep to see if you can pull out anything that you see, you would try to ventilate. If that doesn't work, you would reposition the head, like in other words, reopen the airway, make sure that it's really open, and then try to ventilate again. And if that doesn't work, you start CPR, basically. So based on where you are in this process, you've placed them down on the ground, you've already gotten to the point where you're trying to do ventilations, and it didn't work, so you have to reposition the head and try ventilations again.